هتقدم لنا MRI in diagnosis and staging of uterine cervical carcinoma. يعني يا ريت مثلا تتكلم 25 دقيقة وتسيب لنا 5 دقايق نناقش عشان نناقش بيبر بيبر لأن عدد البيبرز كتير
بسم الله الرحمن الرحيم. أنا عشان سينيور ريزيدنت in Radiology Department. بداية عشان أنا مشغولة مع فرصة وإن شاء الله يبقى ده بداية لأكتيفيتيز كتير في الاسم كله. التوك النهارده هيكون على MRI in diagnosis and staging of uterine cervical carcinoma. Cancer cervix is considered the third most common malignancy worldwide. Typically affects younger women. الprevalence ممكن توصل في third world countries أعداد أكبر بكتير من first world countries. Risk factor include coronavirus infection, multiple sexual partners, early age of first intercourse. في pre-cancerous lesions بتبقى موجودة قبل the development of the cancer itself. ليها كذا classification. يمكن أكتر واحد جديد هو the low grade squamous intraepithelial lesion and the high grade squamous intraepithelial lesion. Human papillomavirus infect the normal cervical tissue. Human papilloma infected cervix may progress into the precancerous and then the cancerous region. We have two main histopathological types: the squamous cell carcinoma, which represent about 90% of the cases, and the adenocarcinoma, which represent about 10% of the cases. The patient usually present with vaginal bleeding or conductive bleeding, vaginal discharge, and sometimes there is no clinical symptoms discovered accidentally during the pap smear. Okay, unfortunately, the pap smear is not available in third world countries or in developed countries. Same thing on the anatomy of the cervical cervix. The cervix is the lowermost part. The lowermost part of the uterus. It's a muscular tube. It has an internal and external os. Receives its blood supply from the uterine artery. And in MRI, in surgical T2 weighted image and in axial T2 weighted image, we can see the trilamellar appearance or the trilaminar appearance of the uterine cervix. The innermost hyper-intense signaling we can see here is the mucus and the mucosa. The low-intensity signal we can see here is the cervical stroma, and the outer layer is the muscle layer. Regarding imaging technique, at first we take consent from the patient. Patient should be fasting. One of the most difficulties in cancer imaging of the pelvis is the peristalsis of the small intestine, which can be reduced by instructing the patient to fast for 4 hours or to leave the patient at peristalsis intramuscular or intravenous. Immediately before imaging, the patient is advised to avoid. The bladder is completely filled. It will cause what's posting artifact and image. MR images are acquired when the patient is lying supine. Surface are required to optimize the quality and reduce the acquisition time. Sometimes we use the vaginal pacification using gel for little dilatation of the cervical anatomy. Individual files are not routine. They make the patient highly uncomfortable. They reduce the view and they are not used routinely in the diagnosis of cancer cervix. The golden sequence in imaging of the pelvis is the T2 weighted imaging. We take it in 3 main planes: axial, sagittal, and cone. We take also axial span equal T1 or T2 of the abdomen and the pelvis. This is detected to be metastasis, erosion of lymph nodes, hydronephrosis, and bone marrow abnormalities. من المهم جدا ان احنا نبقى عارفين ان our line or our organ of target is the cervix. ما ينفعش ابدا ان احنا ناخد الكاتس perpendicular على البلفس or perpendicular على الcervix itself. The appearance of cancer cervix in MRI, this is a sagittal T2 weighted image. This is an axial T2 weighted image. It appears either iso or slightly hyper intense in comparison, of course, to the pelvic muscles. Our reference is the pelvic muscles, iso or hyper intense in relation to the pelvic muscles. This is schedule that represent a summary of some of the sequences taken in diagnosis of cancer cervix. مش كل الاماكن بتعمل السيكونسز اللي احنا كاتبينها دي، ولكن البيزك سيكونس زي ما قلنا هو التي2 ويتد ايمج. الفانكشنال ايمجنج بيشتمل على dynamic contrast enhanced images, diffusion weighted images and ADC mapping and MRIs. They are not routine. Dynamic contrast enhanced MRI له يعني ثلاثة advantages مهمين جدا. أول حاجة in the small tumors which are 3 mm or less to differentiate between the endometrial cancer or cervical cancer when it is arising from the lower uterine segments. Sometimes it can be differentiated. And in the post-operative assessment, the radiation necrosis and the post-surgical effects can be hard to differentiate from recurrent tumors, and the using of contrast material can improve the differentiation between recurrence and post-surgical or post-treatment tumors. As we can see here, this is a sagittal weighted image, diffusion weighted image, and post-contrast T1 weighted image. As we can see here, there is a very small, poorly seen region, appear as an highly intense region, which shows selective diffusion in the diffusion weighted image, and shows intense homogeneous contrast uptake in the post-contrast image. Regarding the pattern of uptake of the contrast in the small lesions, they take vivid enhancement. In the larger lesions, it may show areas of hemorrhage and necrosis and may not enhance as vividly as the small lesions. This is another image of the dynamic contrast enhanced MRI. This is a sagittal T-weighted image, and this is a sagittal T1 post-contrast. As we can see here, the tumor, which is approaching on the vagina, this would alter the diagnosis or alter the staging of the case. Diffusion weighted image diffusion is a physiological imaging technique that provides information about uterine mobility and tissue cellularity. Diffusion weighted image is acquired by sagittal axial peak perpendicular to the cervical canal, and they are acquired in a low and high value. Area of high segment intensity or diffusion weighted image, they represent the area of the region, and they appear as low signal on the EDC map. EDC map can be calculated with images with different p-value, providing a measurement in square per millimeter per second. Co-registration of diffusion weighted image with the T2 weighted image improve the anatomical correlation, and EDC map should be reviewed with the diffusion weighted and the T2 weighted image. This is to exclude the T2 shrine through and the phalluses in the diffusion weighted images. Regarding the staging of cervical carcinoma, the International Federation of Obstetrics and Gynecology only acknowledge two methods of staging, which is the surgical and the clinical. Yet MRI is not a standard or is not a golden standard in the staging of uterine cervical carcinoma. ليه؟ لأن cervical carcinoma is prevalent in third world countries, developed countries, and MRI is not available. International Federation, when it searches for a staging technique or a staging modality, searches for something available. And MRI, unfortunately, is not available in all centers, all health centers. Surgical staging is the golden standard, is most optimal, but definitely most invasive. And the clinical staging depends mainly on the clinical examination under anesthesia, sigmoidoscopy, cystoscopy, plain X-ray of the chest, and IUC. The question is why perform MRI in a patient with cancer cervix? MRI has a superior soft tissue dilation, most widely used imaging modality in the initial staging of cancer cervix if available. Very important to monitor the response and the response of the treatment and to detect the recurrence, to demonstrate complication of the disease and the treatment, to determine the feasibility of fetus preserving surgery and the planning of radiotherapy. The FIGO classification system doesn't use the MRI yet. There is a lot of fallacies and errors in its staging system. We can see in stage 3 and stage 4 there is up to 65 to 90% error in comparison to surgical staging. This is the FIGO classification system. It's divided into 4 main stages, 0, 1, 2, 3, and 4. Basically, we depend on the size and the extension and the depth of invasion of the tumor into the surrounding, and the distal metastasis is considered as stage 2. MRI staging is used to detect important prognostic factors as the tumor size, vaginal infiltration, perimetrial and ventricular wall invasion, bladder and rectal invasion, and lymph node metastasis. Lymph node metastasis is not considered one of the parameters in the FIGO classification system yet. If present, it alters the survival rate significantly. It has been found that in early stages, the survival rate may be 90 or 95%, but if there's a lymph node involvement, it may decrease to 50 or 45%. We have certain points to report when we are reporting acute cancer cells. That's to comment on the tumor size. The tumor should be measured in 3 orthogonal planes, and the maximum diameter greater than 4 cm usually is not available for primary radical surgery. Parametrial invasion. The parameter is anatomical space lateral to the cervix, and the reported accuracy in MRI to detect parametrial infiltration is from 75 to 96%. Command 1 has a very high predictive value, negative predictive value in excluding parametrial infiltration. If we can see the low segment, cervical ring, the stroma, all around the lesion, it excludes by 100% the presence of parametrial infiltration. Vaginal invasion and the replacement of the usual full-segment vaginal wall with high-segment tumor, invasion of the upper two-thirds that would be stage 2A and the lower one-third that would be stage 3A. Pelvic side wall involvement or hydronephrosis extension into the pelvic side wall or hydronephrosis will upgrade the staging into stage 3. Bladder and rectal invasion. MRI has again a high negative predictive value excluding bladder and rectal involvement. Bladder involvement can be seen as thickening of the posterior bladder wall with disruption of the lower signal bladder musculature or a mass within the bladder itself, and rectal involvement is common and can be seen as loss of the posterior fat and direct tumor extension. We can see here, this is stage 2A, this is the lesion extending into the upper third of the vagina. The lesion is isolated to muscle. Another example, stage 2B. You can clearly, this is a post-cancerous fat suppression T1 imaging. We can see here the lesion appearing as an isolated. We clearly here see that there is interruption of the low signal which represents the cervical stroma. This is with equal parametrial infiltration. In the stage 3A, you can see the lesion extending into the upper and the lower third of the vagina, more obviously as the imaging. In stage 3B, we can see the lesion extending into the lateral wall of the pelvis with consequent hydronephrosis. In stage 4A, there is direct invasion of the bladder as visualized here, and as seen extending in the bladder base, and as seen clearly in the axilla. MRI is also used in lymph node assessment. As we can see here in this image, there is enlarged spontaneous lymph nodes. Again in this image. Regarding the lymph node assessment and staging, it depends basically on 2 parameters: the appearance of the lymph node and the size of the lymph node. If the size of the lymph node is more than 1 cm, is considered suspicious, and the patient is advised for laparoscopic staging or laparoscopic sampling before proceeding to a radical surgical intervention. MRI is used in preoperative imaging for local staging of the tumor, and to determine the resectability, select the most suitable operative procedure, which is primarily dependent on the tumor size, lymph node assessment, lymph node involvement, and parametrial involvement. If no primary surgery is planned and no surgical lymph node staging is performed, MRI serves to determine the target performing to be irradiated. In patients with local recurrence, MRI finding has an important role to decide about the repeat the surgery and the surgical technique itself. للأسف cancer cervix affect young age group of the patients. That's why we are searching for a more conservative surgery for fertility scaling. How to decide if a patient is suitable for radical trilacectomy or cervicectomy? If the patient is desired to preserve fertility, if there is no clinical evidence of impaired fertility in stage 1A or 1B malignancy of the cervix, lesions larger than or less than 2 cm, absence of adenocarcinoma and intraoperative pathological displacement, absence of capillary space involvement in intraoperative pathological displacement. All of these are the major criteria, but depending on the MRI, trilacectomy requires the tumor to be smaller than 2 cm and the cervix to be longer than 2 cm and the distance from the internal cervical os to be more than 1 cm. All of these measurements can only be performed through an MRI examination. As we can see in this image, the cervix is removed, and there is primary anastomosis between the vagina and the lower uterine body segment. This is a post-surgical post-trilacectomy T2 image in surgical orientation. As you can see here, there is no cervix. There is marked shortening of the uterine cervix after radical cystectomy. And we advise the patient not to get pregnant for at least 1 year post the surgery, and MRI is the gold standard for follow-up detecting recurrence in these patients. MRI is not only used in diagnosis and staging, but also used in post-surgical assessment. As we can see here, this is a patient who performed a total hysterectomy, tectosagittal weighted image. We can see here the vaginal stump, and this is after vaginal opacification. You can clearly see that there is no remnant tumor, there is no recurrent. MRI is also used to detect and monitor the radiotherapy response. There is a sequential imaging of the same patient. As we can see, here is just a typical image. The patient received radiotherapy. There was bladder improvement. As we can see, there is marked decrease in the tumor cells. MRS is not standard and still under investigation, and a lot of trials have shown that choline peak level, high level, indicate either recurrence or the presence of cancer cells. Yet, still a lot of papers that are under investigation, not routinely used. MRS is definitely used in the neuroimaging, but not used as well in the abdominal and the pelvic imaging. As we can see here, the patient with cervical cancer, there is a large lesion after radiotherapy. We can see there is decrease in size. MRS shows high choline peak before the treatment and after the treatment. The choline decrease and the level peak increase. The level peak increase detect necrosis. EDC can be also, or diffusion weighted image can be also used to monitor the treatment response. Again, this is sequential imaging of the patient, of another patient. We can see there is marked decrease. This is the mass. There is marked decrease in the size and in the segment of the affected patient. Post-therapeutic complication can be also diagnosed through MRI. As we can see here, there is a fist extract extending from the vagina and into the rectum. This is post-contrast T1 imaging. This is a patient with a religious status. We can see more technique of the bladder wall and irregularity. We can also diagnose intravesical hematoma, which may appear some sort of like recurrence, but the contrast enhanced MRI will help differentiate between the hematoma and the recurrence. One of the complications of chemotherapy and radiotherapy is insufficiency fraction. This is the axial T2 image taken 3 years after the end of treatment, which we can see here as insufficiency fraction in the sacrum and in the iliac veins and in the pubic lining. Recurrent tumors. The recurrent tumors is one of the biggest dilemma to diagnose in the cancer cervix. Diffusion weighted image and contrast enhanced MRI can help in this issue. Contrast enhanced MRI will show enhancement in the recurrent tumor. As we can see here, this is an central T2 weighted image. There is a soft tissue region of low signal intensity related to the cervical, related to the vaginal stump. On post-contrast enhancement, there is a vivid enhancement of the lesion, which will diagnose a case of recurrent cancer cervix. There is a large lesion extending to the lateral pelvic side wall. On post-contrast enhancement, we can see contrast uptake in the region with central area of necrosis. Again, this is a case of recurrent cancer cervix. To summarize, over the past several years, the role of MRI in the pathological oncology has evolved. Due to its high soft tissue derivation, MRI now is widely used imaging modality in the initial stage of primary cancer cervix. MRI is widely accepted as optimal for evaluation of important prognostic factors such as the lesion volume and metastatic lymph volume. Studies have shown that MRI has higher accuracy than clinical examination and surgical staging to detect the local extent of the cervical carcinoma. Consequently, the revised video staging system recommended that when available, imaging is to be used as adjuvant to the clinical assessment and staging